And now, without further ado, I would like to welcome to the virtual stage our fearless leader and someone who is just such a joy to get to know if you don't know her already, and such a rock star for our language access industry, someone who cares deeply about language access at every single step of the way, and who truly embodies our mission here at NCIHC, which is to promote and enhance language access throughout the United States. And we're just honored to have her as our president and for her to be joining us here today. Welcome to the virtual stage, Carla Fogren.
So good morning, everyone. I want to welcome you to our inaugural Language Access Congress. I am very excited. My name is Carla Fogren, and I'm the president of the National Council on Interpreting in Healthcare. Just a little background about me for those of you that may not have met me yet. I'm originally from Angola, raised in South Africa. I'm fluent in Portuguese. I'm also trained as a registered nurse. And then I moved directly into language access, first for one little hospital, and then for a much larger healthcare system with 42 hospitals across 11 states. In that role, I served as the executive director for diversity initiatives, which included interpreter services, ADA, and I was also the Section 1557 coordinator. I am now doing consulting on those same issues, but I am so pleased to be here with you today. This year, our theme, Going Back to the Future, is especially appropriate as we celebrate the 25th anniversary of NCIHC. Can you believe it? 25 years. We have the incredible honor of having many of the founders of NCIHC present with us today, and we'll be hearing from a few of them later today. 25 years ago, these individuals, directly or indirectly involved in language access, and located throughout the United States before email and all of the fancy technology that we have now, traveled near and far to meet to start to envision a world in which language access was available to all who needed it in healthcare. I am truly humbled to be president of the organization that they created as we honor the enormous efforts they took to organize and found the National Council on Interpreting in Healthcare, and all that NCIHC, you, and our colleagues in the language access field have been able to accomplish in the last 25 years. We are also very honored to have Melanie Fonts-Rainier, the director of the Office of Civil Rights within the U.S. Department of Health and Human Services, as our keynote speaker. In addition, we are thrilled to have an incredible array of presenters to broaden our knowledge and challenge us to do more. As part of our annual tradition, we will also be bestowing the Language Access Champion Award on Natalia Mitareva, NCIHC's 2023 Language Access Champion. Although this is a time to celebrate and be proud of all of the work that has been done thus far, there is much work yet to do. The road we are on has had its challenges that we have been able to overcome in part, and will continue to present the field and us with many other challenges. While language access is a basic human right, so many go without it, and consequently do not receive quality healthcare that they need because of the lack of access to qualified medical interpreters or to providers who have been vetted and are fully fluent and professional document translators. It is only through your efforts, our combined efforts, that we will continue to ensure that everyone, no matter what their spoken or sign language is, will be able to fully participate in their healthcare. And finally, I want to take this opportunity to thank the Language Access Congress Work Group for their hard work and commitment to organize this wonderful program. And now the National Congress on Interpreting in Healthcare, NCIHC, is proud to offer you this exceptional experience, and we thank you for your continued support. Let the Congress begin. I am delighted to introduce our Diamond Level organizational member, AMN Language Services. Jacobia Solomon is the president of AMN Language Services, and she will be introducing our keynote speaker. Please feel free to submit any questions you have in the questions section of the presentation, and the director will answer as many as possible at the end of the presentation. Now to Jacobia.
Good morning or good afternoon. Today we have the privilege of being in the presence of a true visionary and leader in the field of healthcare and civil rights. Our guest speaker today has dedicated her career to finding innovative solutions for a healthier and more equitable future. Melanie Fontes Rayner leads the department's enforcement of federal civil rights, privacy laws, and directs related policy and strategic initiatives. Previously, she served as a counselor to Health and Human Services Secretary Javier Becerra, providing strategic guidance to the Secretary on issues pertaining to civil rights, patient privacy, reproductive health, the Affordable Care Act, competition in healthcare, equity, and the private insurance market. Before joining the Biden-Harris administration, she served as a special assistant to the Attorney General and Chief Healthcare Advisor at the California Department of Justice, where she led a national team to save the Affordable Care Act. During this time, she also facilitated the creation of a new office, the Healthcare Rights and Access, devoted to proactively, advancing laws pertaining to healthcare, civil rights, privacy, competition, and consumer protection. She also served as the U.S. Senate Senator Aide and Women's Policy Director to Chair Patty Murray on health, education, labor, and pensions, and the Budget Committee. Ms. Fontes Rayner holds a JD from the University of Arizona, a MSME from the City University of New York, Brooklyn College, and a BS and BA from the University of Arizona. She also has a close personal relationship with Ruth Bader Ginsburg and Mookie Blaylock, her dogs. I am pleased to announce Melanie Fontes Rayner, Director of the Office of Civil Rights at the U.S. Department of Health and Human Services, as our keynote speaker.
Thanks so much, Jacobia. Hopefully everybody can see and hear me. My name is Melanie Fontes Rayner. I am the director at the Office for Civil Rights. I am a middle-aged woman with very dark black curly hair. I'm wearing a black turtleneck sweater today, and my skin is lighter. I have light green eyes, and I'm really excited to be here with all of you. Madeline, can you pop up the slide? So language access, I heard our Carla, our fearless leader, say that language access is a human right, and I wrote it down because I think that's such an important thing. I try to emulate in our work and our policy. We oftentimes, I try to zoom back on this issue because I think it's Hispanic Heritage Month. Many of you may know. I am a fifth generation Arizonan. I'm a Mexican American from Arizona. My family's been in the state of Arizona since the 1700s. I think the fact that it is 2023 and in places like Maricopa County, we're still seeing lack of language access services pretty broadly, including in languages like Spanish. I think it shows the need to prioritize this area, the need to elevate this area, and the need to make it a priority so it's not an afterthought, it's something that you're thinking on the front end. Next slide. So just a little bit of background about my office and who we are and the work that we do. I run the Office of Civil Rights at the U.S. Department of Health and Human Services. For those of you that have interacted with us, you know who our office are. I find that most of the time when I speak, many folks, whether it's because of COVID or other reasons, haven't engaged with our office. This is just to give you a sense. We are a nationally facing office. These are the regions we represent. We have 8 regions we represent across the country. In addition to those regions, we have 11 offices across the country in 11 different cities across the country. In those regions, that's where I have my investigators and those teams that are on the front lines of investigation work. If you ever filed a complaint with our office, if you've ever ended up with a resolution agreement or helped somebody get a resolution agreement, it was with one of my regional teams across the country. We are unique to other federal civil rights offices in that we are the only federal civil rights office in the United States, in the US government, that not only mandates and enforces federal civil rights laws, but also that enforces privacy and health information privacy, data, cybersecurity through HIPAA. So we are uniquely situated as we think about folks' civil rights and what it means to their data and the information collected on them. So this is a unique opportunity for us as we think about these issues across the country. Next slide. We all know, right? I'm not telling you anything new here. Language access is such a significant gateway to health and human services. Over 20% of people in the United States speak a language other than English at home. In that population, almost 10% have limited English proficiency. We know that 1 in 4 individuals have some type of disability, and we know that there are high rates of disability and limited English proficiency in certain communities of color and among our low-income populations. The point I'm trying to make here is that this is the perfect storm for somebody not being able to access the healthcare system, human services system, somebody not having communication and ability to talk with a provider or a caretaker or a foster program about their rights or what's happening to them, what's happening to their healthcare, which is a significant deterrent to accessibility and availability of services. Next slide. Again, these are just some of the barriers. Again, I'm not telling you anything new. Challenges making appointments, delay or foregoing care, limited ability to comprehend diagnosis, like also cultural accessibility, understanding that we're a mosaic, not a monolith as we think about our communities, lack of adherence to medical plans, medications, increased surgical delays. These are things that we know through research and study and practice are happening. These are things we've seen through our own enforcement work, and this is why this is a priority area for the Biden-Harris administration. If you've heard Secretary Becerra speak about these things, you know, he grew up in California. His parents did not speak English, and as a child, he had to interpret very complicated medical documents, insurance documents, healthcare diagnoses to his parents, and that it's 2023, and that is still a very common practice for a lot of communities and families, and that our healthcare communities aren't doing what they need to be doing to meet the law and to provide language access services, I think is pretty significant that we have a lot of work to do and we need to do more. Next slide. Next slide. So in our work, we talk about federal civil rights laws. In my neck of the woods, that's Title VI of the Civil Rights Act, right, which prohibits discrimination on the basis of race, color, national origin, in all programs assisted by federal funding. So at the U.S. Department of Health and Human Services, that is not only our healthcare programs, but also our human services, right? The programs administered by the Administration for Children and Families, you know, our Office of Refugee Resettlement Programs. Across HHS, these laws apply, there's no distinction. And then we know that Section 1557 of the Affordable Care Act went a step further and it prohibits discrimination on the basis of race, color, national origin, sex, age, disability in certain health programs or activities. And again, it allows us to do things in the insurance context that allows us to do more in this space, but is a really important hook. When I talk about language access services, I like to talk about not only limited English proficiency, which I think is traditionally how it's been categorized, but I also like to talk about effective communication for persons with disabilities, because I think both of these things are gateways that can provide barriers if they're not done the right way and not prioritized to people getting their federally entitled health benefits or services. Next slide. This is just a little bit more specific on the basis of disability. Section 504 of the Rehabilitation Act. Some of you might be tracking, we just recently proposed a notice proposed rulemaking in this space to update these regulations because they haven't been updated since 1977 when they were first introduced. Prohibits on the basis of disability, and Section 1557 gets us our basis in insurance context, which we're working on finalizing that final rule based off of the notice proposed rulemaking we issued last year, as well as our authority under Title II of the Americans with Disabilities Act, which is specific to state and local government programs, and our office uses frequently. Next slide. We also talk a bit in this space about what is the baseline here, what is required. So the law requires covered entities. When I say covered entities, I'm talking about whether they have federal financial assistance. So that can be a grant, that can be a program administered by the U.S. Department of Health and Human Services. We have to have a federal funding hook in order to use these tools. So those covered entities, whether it's a grantee, whether it's a clinic, whether it's a provider, it's a hospital, whether it's an insurance company, to take reasonable steps to ensure meaningful access for limited English proficient individuals. In the disability space, that requirement is to ensure communication with individuals with disabilities and companions with disabilities are effective as communications without. And a lot of the cases, we'll talk a bit more about our enforcement of the space, really is about this nexus with companions specifically, and those companions being denied entry into an emergency department visit with an individual and otherwise. Next slide. We know in the language access space, we have done a lot of work in this space. We've put out a lot of guidances. I believe there's a slide in here with those links and we can send them around. But we know that there are best practices here, and they're practices we're employing here at the department. So developing a language access plan, we are working on this now. The department, this has been a priority area. This is something that went a little sleepy over the last administration, and so is sort of being woken up and given some coffee to get going, making sure that across our agencies we're adequately funding and staffing call centers to ensure they're accessible without prolonged delays. I think this really hits a button when you think about the Medicaid unwinding process right now, where we have millions of people across the country who are having to redetermine their eligibility for the Medicaid coverage program because of the end of the public health emergency and the need to do that. And so this has really been a focus for the Centers for Medicare and Medicaid Services. Our office has done work in this space to alert state Medicaid agencies and states to this, providing materials in large print formatting, Braille and other accessible formats as needed. Again, and this is something that's very personal for me. We know 7 million people across the US are visually impaired. That number will grow as our population gets older. And in this population, we know a lot of these individuals, oftentimes, not because they don't have coverage, they do have coverage, but they're not getting bills, they're not getting information about their medical treatment in the right size font. And so this is something we think is really important to flag up front, because to me, there's a bit of an echo.
Melanie, just a quick interruption. I apologize. On behalf of the ASL interpreters, they're asking if you could just slow down a little so that they can keep up with you. Thank you.
I'm so sorry.
Not a problem.
Can you hear me?
Yes, we can hear
Sorry,
you.
I talk a little bit fast. I apologize.
No problem. Thank you.
So it's ironic, right? Slow down for the ASL interpreter as I talk about best practices for effective communication. My apologies. So we know that there are a lot of Americans in this country who aren't getting appropriate information about bills, aren't getting appropriate information about their medical treatment because it's not in the right font size. And again, in an industry that has a lot of resources, this to me just feels like something we can fix and we should prioritize to fix. Ensuring that websites, information kiosks, and other information and communication technologies are accessible to individuals with disabilities. Again, we've taken this a step further in our proposed rule, where we're actually putting an enforceable standard in place. But this is something that, if you or a loved one have been to an emergency department, an urgent care clinic, a lab to get blood drawn in the last couple of years, you know, gone are the days where there are people at the front desk, right? And that you're actually doing a lot of your business on an information kiosk, which is not always accessible for persons with disabilities. Providing notices and other vital documents in the top 15 non-English languages spoken by individuals with limited English proficient persons in your states. Again, this is something we see a lot in our work where we're seeing these languages just this is not done in the appropriate way, or the services and translation are not provided. We see providers sometimes trying to use Google Translate, which we know is not a one-to-one translation and can have implications for how a medication is taken or how a person perceives their treatment because it's not a straight translation. Providing notices, informing individuals of the availability of language access services and auxiliary aids that they'll provide it free of charge and how to request those services. Again, we know that these are steps that are not always taken. People don't know that they have this right. And so then it impacts their care because they don't figure this out until the back end when they've already had a bad experience with the healthcare system or the human services system. Ensuring that individuals serving as interpreters, including sign language interpreters and translators, are qualified, which I'm sure is a particularly acute concern and need of this group, and having translated materials drafted, reviewed, proofread, and edited by qualified translators rather than machine translation applications or software. Again, we know it's not a one-to-one translation, and we know that that can have pretty broad sweeping implications for a patient's health, a person's human services. And so these are really important best practices we try to employ, and we tried to work with covered entities across the country to do. Next slide. Next slide. So we're talk a bit about our, go back. We'll talk a bit about our enforcement here. I think it's a really helpful tell about how the Office for Civil Rights is thinking about these issues, how we're enforcing these issues. And I think, to me, this is a really important area because it shows other covered entities, whether it's a city, it's a county, it's a hospital, they can see how not to do something or how to correct what they might already be doing. So I talked about this example a bit earlier in the presentation. Maricopa County is the largest county in the state of Arizona, and it's actually where I'm from. And we know that Maricopa County has a very, very large Spanish-speaking population. In particular, it's a growing demographic in the community. OCR initiated an investigation with Maricopa County Superior Court after receiving complaints that it failed to provide individuals with limited English proficiency involved in the child welfare proceedings with language access services. Our office identified these issues with the availability of translated documents such as court orders, pleadings, minute entries, other documents related to the individual's rights and justice. The court agreed to take these steps to ensure that individuals with limited English proficiency are provided meaningful access to justice in court proceedings, operations, programs, and activities, including notification to individuals that free language access assistance is available, training their staff, among other things. And I like to point this out because this is a very, very large county in the United States. It's a county with a very diverse population. So the fact that they were not doing these baseline documents that really were the entry point for access to justice, right, in the child welfare system, they weren't translating them in Spanish, I think is a pretty significant tell for how language access is being implemented across the country. Now, Maricopa County came to the Superior Court came to the table. They worked with us. We're monitoring them. We have an agreement in place. They're changing their practices. That's great. And so again, we want to flag this for other communities and other actors across the country because, again, you can imagine, right? And I'm sure we've all heard these stories. I know I have heard them in real time from patients or advocacy organizations or legal organizations about the impact of what it means when you don't have the right documents or a translator when you're trying to access justice for your child, or you're trying to access placement of a child, or you're trying to make sure that families are not separated. Next slide. This is a health care provider. It's a federally qualified health center. I flagged that again, not to pick on them, but to say that, we all have had interactions with federally qualified health centers across the United States. They are the entry point for many individuals, including individuals, immigrant communities, entering into the healthcare system, getting, free or low-cost healthcare services. This particular facility, so it's a federally qualified health center, we received a complaint that they failed to provide a patient's companion with an ASL interpreter. Again, this is the law, it's required, but we see this all the time. I don't think that the covered entity here, this clinic, I don't impute bad faith on them. I think that they're a small qualified health center and they weren't necessarily understanding the requirements under the law. So they have now agreed to allow for the ASL interpreters. They're taking steps to train their staff. They're taking steps to ensure the availability of auxiliary aids and services to patients, companions, and members of the public who are deaf or hard of hearing. After we worked on this agreement, we worked with the Health Human Services Resources Administration, HRSA, to think about how we're communicating more broadly to federally qualified health centers. Because again, we don't think this covered entity, most covered entities don't intend to break the law, but they might not just know what their federal obligations are or have appropriately allocated the resources to bolster those requirements. Next slide. We talked about this a little bit earlier, and I think it's such an important thing for this community. And I think it's really important for this moment in time. So the Medicaid program, which is a coverage program that is really important to millions and millions of families and individuals across the country, is currently going through a redetermination phase where those individuals, those families are having to go through their states to redetermine their eligibility for Medicaid, that coverage. And we know that across the country, these efforts look different, and we know that across the country, they're impacting communities differently. And so based off of what we were seeing on the ground and based off of some of the reports we were seeing, we issued a letter to state health officials reminding states of their obligations under federal civil rights laws with respect to language access for limited English proficient individuals and effective communication under our disability laws. And this was both in the Medicaid and Children's Health Insurance programs for those eligibility reviews to remind these states of their obligations, because what we were seeing was even on some websites, the number of languages wasn't the right number. People weren't getting the appropriate services in call centers. The attention wasn't being given to effective communication for persons with disabilities, interpreters, translation, auxiliary aids. So again, we issued this letter in April. And so we're trying to work with states to make sure that these individuals are not falling through cracks, right? They're not losing their eligibility because the state didn't prioritize their method and means of communication. And again, this is just the power of communication. In this specific instance, if it's wrong, right? If it's not handled appropriately, it might mean that someone doesn't have coverage, which is pretty significant to your health and your wellness. So again, this is a really big priority area for the Biden-Harris administration. And it's one we are actively monitoring across the country. We have open investigations. We're trying to work with a lot of states, but it's something we want to highlight again, because I think as folks think about this process, they might think this is separate from what it means to have eligibility. And realistically, if you can't read the documents you're getting in the language that you should be getting them in, or you can't go to a call center and get information or eligibility help in the language that you need it in, or you can't get auxiliary aids or an interpreter or translation to help you, then how are you going to have that eligibility? They're connected, they're interconnected. And so it's really important, we think, for this population and community that we focus on this, and it's something that we're prioritizing at the Office for Civil Rights. Next slide. So this is just some of the steps that HHS has taken to better prioritize this area within the department. OCR, my office, the Office for Civil Rights, chairs the Language Access Steering Committee. This is a committee that has representation from every single part of HHS, whether it's the CDC or CMS, the NIH, the FDA, you name it, they're part of this committee. It is the department's collective action and plan to prioritize language access and to make sure that we're being consistent and prioritizing this across every single part of HHS. So whether or not you're a grantee, you're a patient, you're a beneficiary in one of our programs, that you have consistent access to the services the federal government is affording you. This was relaunched last year for the first time in a couple of years. Through this process, we're working with each part of HHS to improve meaningful communication and working with each HHS agency to reassess and update their language access plans. We're working on that right now, and we expect to have work product to share with everybody soon. And we're working, we provided an annual report to the secretary it's public, on the department's progress toward achieving the language access goals. Next slide. This is just to show you what we found through this process, the components, where they didn't have a plan, where they had a plan. Again, we think it's really important to be transparent about this. It's something that my office enforces even amongst, so not just like a federally funded activity, but we also enforce this to other federal agencies. And so it's really important to be transparent about what we're doing and to show the places we need to improve. Next slide. These are just some of the flags from the annual progress report. The Office for Civil Rights, did a joint compliance review with, on behalf of HHS, with the Department of Homeland Security and FEMA regarding allegations that 19 states failed to provide meaningful access to their COVID testing, inoculation, and treatment programs. In response to this, CDC established a rapid response language access team to produce COVID-related content. Centers for Medicare and Medicaid Services launched 1-800-Medicare, which answers with a prompt in Spanish for callers needing assistance in Spanish. We did a compliance review of these states. We worked with these states to provide technical assistance in the public health space to make sure that they are providing for meaningful access for COVID-19 process procedures and public health activities. Next slide. Go back. So again, these are just these are things that I don't necessarily own, right? My office does not give out grants. Other parts of HHS do. So here, these are just some identifiers across the department as we focus and prioritize on language access. We know that it's not only the law enforcement component, having a plan and the policy, it's also making sure that we're investing in this work. So some of these efforts, the Health Resources and Services Administration, otherwise known as HRSA, just this year awarded $8 million to 18 institutions to train primary care medical students, physician assistants, medical residents to provide culturally and linguistically appropriate care for persons with limited English proficiency and individuals with physical or intellectual or developmental disabilities. In addition, the Office of Minority Health did launch an initiative promoting equitable access to language services in HHS, awarding grants to 11 organizations to provide that language access care, informing individuals with limited English proficiency about the availability of their services. Again, I think about my own family, right? Whether or not my mom, right, who is, a senior with a disability, lives in Phoenix, would she know her rights? Would she be able to find a federal website? How would she do that? And we know that in many cases, the answer to that question is no. So we have to think about how do we partner with community organizations to better inform people of these rights and services? How do we better provide these services as an agency? And how do we work to make sure that we're training on the front end, the providers, as well as those in the pipeline to be providers, to make sure that they provide culturally accessible, linguistically appropriate care. Next slide. These are just some of the priority areas. We've covered on most of these things in this presentation. We talked about the updated and revising of the HHS language access plan. We've talked about the components across HHS will each have individual plans. They will be public. They will be updated on a regular basis. Many of them already have plans that are in the process of updating them now. We at the department have also hired a language access coordinator. That coordinator is working to provide technical assistance across all of these components on their plans, helping them with some of the compliance issues we work on, and making sure that HHS is being consistent across each of its parts when we think about this area. And then we're also in the process of establishing a language access center within the Office for Civil Rights. Next slide. Last slide. I just want to present this information here. At the top is the website we have for limited English proficient individuals. You can see the website. It has a lot of our guidances, information fact sheets on the law. If you want to or you have questions, you can email our language access coordinator. Here is the email for this individual, languageaccess@hhs.gov. You can sign up for our listserv at hhs.gov, and that will give you access to our email alerts when we update rules, guidances, enforcement activity across our listservs. It's a good way to stay in touch with the work that we do. You're also able to file a complaint if you feel like you've been subject to discrimination on the basis of your race, ethnicity, national origin, disability, gender, sex. You are able to file a complaint with our office. While we have these ongoing efforts, we continue to enforce 1557, Title VI, so you continue to have those rights. I get asked a lot about individuals that may not want to file a complaint because culturally it's not something that they would do or they don't feel comfortable with. But if they share that information with a provider, if they share that information with an organization, can that organization or provider file on their behalf? The answer is yes. At some point in the investigation, we may need to seek consent so that we are able to get additional information from that individual. But again, you can file a complaint with our office. And then we have a Twitter icon here, which we need to update, Madeline, because I think that Twitter doesn't use that bird anymore. So you can follow us on Twitter. I think it's like an X now or something. I don't know. But it's another way you can stay in touch with our office. And we think, then we post a lot of our information resources there. So that's it. I think we can open this up to questions and we can take the slides down.
Thank you, Director Montes Rainier. That's just an absolutely wonderful, wonderful presentation. We are so grateful. And it feels good to see such movement that's taking place. The first question that we have a lot of questions and we won't get through them all. So I'm just trying to field the ones that I feel that I saw them on the screen that they were repeats. The first one was that we're all excited to know when the proposed rulings will be released. Do we know when that might happen?
Yeah, so it's a good question. It's not something we will specifically comment on. I believe the Unified Reg Agenda, which is a publicly facing document, if you just Google Unified Reg Agenda, you can see we have goal deadlines in there for each rule. I believe the goal in there is by the end of this year for 1557. And then 504 just was promulgated. So that's actually still in comment period. I'm not sure what the entry says in there, but that's the best place to check that information out. They're both significant priority areas for the administration, for President Biden, Secretary Becerra. So it's something we're working on, and I think more to come from us. And if you sign up for our listserv, if you follow us on Twitter, you'll certainly get the updates there.
Oh, wonderful. That's really good. That's really good for us to know. We have a question in regard to, during the pandemic, many institutions tried to use AI or machine translation to provide information in multiple languages with very poor results. Can you speak to what enforcement action OCR has taken to clarify whether these tools comply with civil rights requirements?
Yeah, so we actually do have, the thing I like to remind folks of is that much of our compliance work is resolved behind the scenes. You might not see a press release, you might not see that we work with a covered entity, but oftentimes we're driving compliance by helping those entities get on track. So the investigator might be calling a hospital and saying, you can't use this translation, it's not appropriate. And then it's resolved and you never see the output of that. Specifically on predictive analytics, clinical algorithms, artificial intelligence. I know it's a really hot topic right now, and it's one in which I like to remind folks, it doesn't matter that these are new tools in development, the covered entities are still required to follow federal civil rights laws. So we know that some of these predictive analytics, clinical decision-making tools can be discriminatory, and we know that in the healthcare space specifically, right, there's already a number of health disparities, whether it's for persons with disabilities, it's for communities of color. There's a lot of research and evidence to suggest that these tools, while they can be groundbreaking in many respects, must be monitored, must be audited, because we know that they can have and further those disparities and discriminatory effects on people. An example of that is we know during, for example, we've had child welfare cases where these kinds of tools have been used. They have discriminated against parents with disabilities. And we know that that's not allowed, right? Your disability is not a mechanism that can keep you from keeping your child or keep you from having a foster youth. We know, right, that there's evidence to suggest that there are delays in care for Black and Brown kids who their delays in cares are not because of anything related to their health. It's just because they might receive or enter into a healthcare system later than a similarly situated kid elsewhere. That delay could have a discriminatory effect if we use a predictive analytic that then delays that care or treats them like they're healthier based upon a disparity. So we have a proposed provision on this in section 1557. It very clearly says you can't use predictive analytics, clinical algorithms that are discriminatory. We're working on finalizing this provision across the rule and other provisions, but I like to remind covered entities, it's already illegal. So, you need to really think about when you use these tools, how you're monitoring to make sure you're not creating a bad situation from your patient population, you're not furthering to health disparities. We've seen them in the crisis standards of care context. Like we've seen them and we've had enforcement experience. So it's not new to us. And really, it's illegal. So folks need to think about how and when they're using these tools.
Well, that's a good direction for us to look at and think about. We think AI is new, but then you're aptly pointing out that this has been an issue for some time, but just not an AI venue. There's a good question that's come up, and it says, what are your recommendations for providing language access for Indigenous First Nation languages? LLD are prevalent in many states where agricultural workers, pickers, etc. Exist, yet most states ignore this segment of the population. There's a real challenge of finding qualified interpreters as well. How can we create a protocol that all can follow? Can we create a national database?
Yeah, I think that's a good flag. And we have had direct enforcement experience with this in some southern states where we've had in the child welfare context, kids being removed from their families because of a language barrier with respect to Indigenous languages. We understand the challenges with finding those translation of services. And I know that's something the department is working on. And it's something that we're trying to be very thoughtful about as we think about the standards we're creating in 1557, but it is something we've had enforcement experience with. And so I think if there are specific examples of that where you think that it's not being done right, I think filing a complaint or reaching out to our office could be a good first step.
Awesome.
And also noting, right, we do health and human services. These, Title VI applies across other agencies, right? So we work very closely with the Department of Labor, HUD for housing, the Department of Education. And so as these cases might pop into other spaces where my office doesn't have jurisdiction, we certainly work close with other agencies and can identify these same issues there.
Yeah. As you know, I'm sure you're very aware of the new law in Florida, the SB 1718. Among other things, will require healthcare providers to collect information on patients' immigration and citizenship status. This is creating a lot of fear and hesitation in the immigrant communities. Is there anything legal prohibiting states from doing this? And I guess the concern is could this spread nationwide, and would it be legal?
Yeah, so I will say, certainly it has a propensity to spread. I mean, I am from Arizona, right? I mean, we had a law where citizens could be asked to identify their immigration status on, transportation screenings pretty regularly, and pretty prominent folks in the state were targeted. So I will just say it certainly has the propensity. I want to be careful about how I talk about it, in part because I believe it's public that a complaint was filed with our office. So we really can't speak about the specifics to say, but we are aware of the issue and we're closely monitoring it.
All right, okay. There's a question, probably a really good question. Is anything being done to increase the number of OCR investigators? I understand that the investigations are often limited to availability of investigators. And I suspect that that's probably a pertinent question because we all worry about our communities and would like to see resolution of issues. And you need the staff.
That's a great
to do that,
question.
right?
Yeah, so that's a great question. And our budget, both last year and the year before, had significant, I believe the plus up last year was a 40% plus up, in part because OCR's budget has been the same since over 20 years, meaning that our budget has been flat funded for over 2 decades. And that is not inclusive of the work we do in HIPAA. So again, we're a unique civil rights office. We don't just do civil rights, we also do privacy, which means we have to be very strategic about the cases that we're able to resolve, the cases that we're able to investigate, and really think about the most impact from those cases. I will say, and I've publicly said this before, when I first started last July, OCR had the lowest number of investigators it's ever had. So we had the highest complaint volume last year at 51,000 complaints, and the lowest number of lowest number of investigators ever had at 61. That pales in comparison to other agencies, like the United States Department of Education. It's something we're working on prioritizing. So our goal this fiscal year is to get our number of investigators up to 100. By the end of this fiscal year, which is now, we are up to 101. So we're making progress. It's still not enough, and we continue to work with our secretary and Congress and others to try to highlight the needs that we have, but it's something we're trying to be creative about and work on. And so we have increased the number of investigators, which has been helpful and allowed us to do more of this work.
So while you may not be able to say this, perhaps I can, I hope, is that for us to be active and write to our Congress people to help fund the situation for your office.
I'm definitely not allowed to say that.
I know you're not, but I thought I could. Are language access plans required by OCR section 1557? Will having a language access plan in place help if there is a complaint or grievance filed with OCR?
Yeah, I mean, I think when we do enforcement, we always take into account, right? Was there a plan? Was there a policy in place? But it's more than just having, right? Like we have these, and we have these cases, right? Especially in the HIPAA context where somebody might have something on paper, but they're not implementing it in practice, right? And so, yes, we take that into consideration, of course, but we also take into consideration, what does that mean? How is it being employed? I think we oftentimes will see and have seen this. The plan is, there is a point of contact in a document, and that's it. And that is not sufficient. And so making sure that it's not just the plan on paper, that we're actually training staff, that staff understand the requirements of federal civil rights laws, and making sure that we're taking those steps to drive compliance.
Awesome. You had mentioned in regard to Section 504, and maybe if you could talk a little bit more about that in terms of disability rights as civil rights that was just announced in early September.
Yeah, so we issued a proposed rule in early September. So the 50th anniversary of Section 504 of the Rehabilitation Act was this week. We're really excited to celebrate it. The White House hosted an event at the Department of Education with us and HUD. So we're really excited about the work. But we issued a proposed rule. This rule, among other things, for the first time, requires that medical equipment be accessible. So we know that many people with disabilities may forego preventative treatment, screenings, and care because accessible equipment is not available to them, or they have to drive several hundred miles an hour to get it. So a lot of women who, because of their wheelchair, have foregone a mammogram or a pap smear. And we know, like, we have a lot of data to suggest this is a pretty common thing. So the rule itself requires accessible medical equipment for the first time. And that will be enforced by my office. It requires that medical opinions and judgments be based on science and evidence, not stereotypes or bias. Because again, we saw this during COVID, right? We see this pretty regularly, that there, in spite of the progress we've made, that there are still policies on the books that might treat people with disabilities like they are not eligible for something or treatment or care based off their disability, right? Or have a stereotype written into a policy. Again, we saw this during COVID, where a lot of hospitals, cities, counties had policies for crisis standards of care for a public health emergency that had not been updated in many, many years, that said a person with a disability could not have, a ventilator because they had a disability, treating a person with a disability's life as less than a person without a disability. That's illegal. Making sure this rule for the first time implements and has a standard, an enforceable standard for web kiosks, web accessibility. Again, this is so prevalent in the healthcare space, right? Kiosk, web technologies are used rampantly. My mom lives with me. She's 74. She's blind and losing her vision in her other eye, and she cannot use a kiosk. It's not possible. So if I don't go with her to the appointment, oftentimes she has to wait extra long to get a front desk person to help her. Or sometimes, right, there's other people in the lobby who see she's struggling and will help her. But that shouldn't be the baseline. She shouldn't have to be reliant upon a stranger's, kindness or not kindness, or have to wait extra long because she requires accessibility, availability of these services. The rule also, for the first time, makes very clear that discrimination on the basis of disability is not allowed in the child welfare context. Again, we see this a lot. We had an agreement just recently with the state of Pennsylvania where their human services department did not have non-discrimination policies and was denying placement of foster youth because of a person's disability status. And they came to the table, they're doing the right thing, we're working with them. It's really great and wonderful, and I'm really proud of that work, and I know the state is proud, but that's something that is pretty common, I think, in cities and counties and states, especially in the child welfare context. The rule also requires that individuals have the most integrated healthcare setting, right? So that we're not forcing people into institutions, and we're allowing people to be in home and community-based services, right? This is the rule tracking with where the Supreme Court and federal law has developed in a way that was necessary. So we're proud of the rule. The comment period is open until November 13th. Folks can comment. It's on our website. It's on our social media. It's up on federal regulations.gov. It's up on the Federal Register. But I think it's a really important opportunity. And again, as I started here, as we think about communication, as we think about language, we want to really talk about the interconnectedness of both limited English proficiency and what that means, but also effective communication for persons with disabilities.
Wow, lots of great work, lots of great work. Director, you had mentioned briefly in relationship that there were allocated monies now, please, if I misstated this, correct me, is to provide education for healthcare professionals. And a question came up is, do you have any plan to promote the culture education in medical school and nursing schools? And it says, because from time to time, I've encountered providers who are not very cooperative with interpreters. And I think basically is also stating is that we really need to infuse the information, about language access and cultural aspects that pertain as well. And could you speak maybe a little bit more about that allocation that you were talking about earlier?
Yeah, so I talked about two allocations of funding, one from HRSA, which was for providers in that training. They've given out dollars both in the limited English proficiency space and also in the disability space to a number of institutions, as well as the Office of Minority Health, which has put out dollars specifically for community-based organizations to try to do that education and awareness of language access rights. My office separately has in the past and is continuing to think about how to bolster this, worked with the American Association of Medical Colleges to do a training on language access and bias through federal civil rights laws. And again, we think it's really important on the front end while our providers are being trained to make sure they have this visibility and awareness. Because, to be a healthcare provider is a tremendous undertaking, right? We ask so much of our providers and our providers do so much. We all know that. But I think reminding folks on the front end of their careers, the importance of these issues and the possibility of biases and how they might play into federal compliance, we think is really important. And so we've been doing that for a number of years now. We're working to think about how to expand that to a broader audience within those medical schools, but it's something that we think is really important.
Yeah, it really is important. And I think that healthcare professionals in particular need the tools so that they can, provide the care in a culturally and linguistic way that's appropriate for our patients, basically. So thank you. Thank you very much. And it's a very important aspect. Here's a question that probably you do get asked a lot, but I will ask it, is what is the penalty for non-compliance?
Yeah, so when my office itself we don't assess like a dollar penalty. We don't have that. We don't do that with respect to language access. So typically, I think of us in two lanes. One, as I said before, many of the complaints we get are resolved by technical assistance between one of my investigators and somebody at a healthcare system, a provider's office, a clinic, dentist, whatnot. So those are situations where we get a complaint, we reach out, they say, oh, they didn't know, the person gets access to an interpreter, or they change their policies, or we find out they've already corrected the situation, right? That's a lot of those cases, because again, my job is to drive voluntary compliance with the law. I'm not looking to get you. I'm not trying to be the law enforcement busters on this. Really, it's to everyone's interest, including OCRs, to have people follow the law in the first instance. In the second lane, I would say we sometimes find that the problems are broader. The problems are more systematic to an organization, and they have impact to other people. And so those are the situations like the clinic I had flagged, where we enter into an agreement with the organization. That agreement has corrective action plans so that the organization is agreeing to what steps they will take to correct the bad conduct, whether it's training, posting a non-discrimination policy, making patients aware of that policy, training staff on that policy, making sure it's posted in their lobby, right? Like we've all been to an emergency room and seen the many notices. Now that I have this job, whenever I go to a facility or emergency room, I always take a picture of the notices because I try to do a comparator and I want my staff to make sure it's accurate. But those are largely the agreements we enter into. If it's something unique or specific, we end up adding additional provisions. But it's something that's typically the lane we'll travel in if we end up into an agreement with an organization. And if sometimes we work with the U.S. Attorney's Office, sometimes we'll partner with a specific U.S. attorney. They have different authorities than us. And so they might be able to impose a civil penalty, but we don't.
Okay, thank you. There's another question that came up that I think is a good one, because I think that us that have been in this a while were influenced by this. The question is there an LEP population minimum threshold to provide language services for federally funded healthcare organizations?
The question is whether or not there's funding for those organizations.
No, is there an LEP population minimum threshold to provide language services for federally funded healthcare organizations?
Yes, right. That's the 15 languages we talked about. That's part of 1557. I know the Centers for Medicare and Medicaid Services, they also have requirements with Medicaid and Medicare, but yes, there are requirements around that. And that's something we're updating with 1557. And I think we'd welcome the opportunity to come back and talk to you all after that rule is finalized to talk about what it does and how it's going to affect this area.
All right. So I see that
Perfect.
David
Time
Brackett
check.
has come back, and I want to thank you very, very much. We're all very thrilled that you've been able to spend some time with us today. Thank you very much. Go ahead, David.
All right, thank you. Thank you so much, Dr. Melanie. That was incredible, such amazing information. And what I love is that we can see how everything is pieced together, right? From what we're doing at the government level to what we're doing as interpreters, as translators. It's all tying together. We all play such a vital piece, and ultimately the same goal, which is language access for everyone, regardless of where they're at. No matter what language they speak or sign, that they have the same opportunity to fully participate in their healthcare, and that's the mission here at the NCIHC. And really, it's so great to be able to see that there are changes coming. They don't happen overnight. It's a marathon, but little steps. Everything that you do as someone who's in our industry is helping us get there. So, thank you so much.